I think we can start. We have Dr. Shehnaz with us as well. So,
Yes, I think so. Go ahead. Let's
yes.
start.
Okay. So, Assalamu alaikum and good evening. Thank you for joining us tonight at our third peer-to-peer webinar series. We are very excited and indeed privileged to have a very esteemed lineup of judges with us tonight. So I shall start off by introducing, well, of course, Dr. Shahnaz Ibrahim does not need an introduction. So I'll just give a brief overview. Ma'am has been associated with the Aga Khan University for now over 25 years. She has pioneered the pediatric neurology program here and also started the first structured program way back in 2009. She's also the pioneer and director of the child development program here at the university. Next, I shall introduce Dr. Gohar Javed amongst our judges. He is an associate professor and section head of neurosurgery at the Aga Khan University Hospital and has an special interest in pediatric neurosurgery. We also have with us tonight Dr. Mohammed Wasim joining us from the United States. Dr. Wasim is currently the professor of emergency medicine and pediatrics at Weill Cornell Medical College, New York, and an adjunct professor of emergency medicine and pediatrics at New York Medical College, Valhalla, New York. He also happens to serve as a research director for the emergency medicine and vice chair for the IRB at Lincoln Medical College Center, Bronx, New York. So we welcome Dr. Wasim, Dr. Shehnaz, and Dr. Gohar Javed. We also have Dr. Ataullah and Dr. Humaira Jureir with us joining us tonight. Dr. Humaira is a good colleague of ours, and currently she's working as a pediatric intensivist at the Indus Hospital. And Dr. Ataullah joins us from Shifa International, Islamabad. So we welcome all our esteemed judges. I, along with my colleagues, Dr. Naveedur Rahman, Dr. Kalbe Abbas, and we also have Dr. Sarwar joining us from Lahore tonight as the moderator for tonight's session. So we have Dr. Nazia Malik, who shall be the presenter tonight. She presents on traumatic brain injury. Dr. Nazia is Year 2 Pediatric Critical Care Medicine Fellow with us at the Aga Khan University Hospital. A few ground rules before we start off with our presentation. Kindly keep yourselves muted during the presentation, and you are more than welcome to share your questions in the chat box. We shall take all questions and queries at the end of the presentation. So without further ado, we can start with the presentation. So welcome, Nazia, all the best. The floor is all yours.
Okay, Assalamu alaikum and good evening, everyone. Can everyone hear me?
Yes, we
Hello?
can hear you.
Okay. So I'm Nazia, and today I'm going to talk about one of the most important topics of the neurocritical care, that is traumatic brain injury. What an intensivist need to know about the traumatic brain injury, we will discuss about that. I do not have any disclosure to declare. I shall be starting my presentation with a case scenario. So a 9-month-old child who suddenly fell from a bed had one episode of generalized tonic-clonic seizures with opening of eyes followed by vomiting and loss of consciousness. So the child was brought to the emergency department, and on examination, child was having marked pallor with the shallow breathing GCS of 9/15, was having decerebrate posturing tachycardic with the poor pulses and perfusion, and the pupils were bilateral and isochoric. The emergency CT scan head was done, and this is the CT scan head of the kid. So how will you proceed to manage this kid? Then the case scenario 2, a 14-year-old child riding a bike without helmet had a collision with upcoming car. So an examination, the child was attended with a shallow breathing and GCS of 6/15 and was having the multiple aspirations on the face with the right-sided vacuum eye and with the ear bleed. And the pupils were mid-dilated and fixed. And this is the CT scan brain of the child. How will you proceed to manage this kid in the emergency department and later on in the ICU? These are the objectives of my presentation. So how do we define the traumatic brain injury? It is a non-degenerative, non-congenital insult to the brain from an external mechanical force that is potentially leading to the permanent or the temporary impairment of the cognitive, physical, and the psychosocial functions with an associated diminished or the altered state of consciousness. Regarding epidemiology, it is one of the leading cause of death and disability worldwide, and it affects around 280 out of 100,000 children worldwide. Approximately 50,000 children are disabled due to traumatic brain injury each year. In 2016, the number of the prevalent cases of TBI was 55.5 million. And from 1990 to 2016, the age standardized prevalence of TBI increased by 8.4%, and the age standardized incidence rates increased by 3.6% for the TBI. The falls and the road injuries were the leading causes of new cases of TBI in most of the regions. Regarding the causes of the TBI and the traumatic brain injury, it can be caused by a blunt trauma or a penetrating trauma or by the secondary to the blast injuries. The blunt trauma can be secondary to the high velocity motor vehicle collision, or it can be secondary to a low velocity like falling from a roof or fall from the stairs, or any physical assault that is more common in the children less than 2 years of age. Then it can be because of the penetrating trauma to the skull and the brain, can be secondary to the gunshot injury or the stab injury. And the last but not the least is the blast injury. The leading causes of the TBI in the United States are 55% are secondary to falls, and the 24% are secondary to the unintentional blood trauma. And in the children younger than 2 years and younger than 4 years of age, the physical assault is the #1 cause of TBI-related death. Regarding pathophysiology, there are the two main injuries leading to the deleterious effects of the traumatic brain injury. The first one is the primary injury that is happening at the moment of the injury, and it because of the mechanical force that is applied to the skull. And then the secondary injury, it is because of the number of the factors I will be talking in the next slide, and it occurs the days or the hours after the injury. So the primary injury, it can be subdivided into because of the direct contact with the skull or the brain, or it can be because of the shearing forces or the acceleration, deceleration injury. So the contact injury, it can lead to the injury to the scalp. There can be a structure, there can be a skull fracture, or there can be the underlying surface contusion. Whereas the injury because of the acceleration, deceleration, and the shearing forces, it can result in the intracranial hematoma. It can be subdural, epidural hematoma, or the subarachnoid hemorrhage, or it can lead to the diffuse axonal injury. So because of the unrestricted movement of the head, it leads to the shear, tensile, and the compressive strains, causing the intracranial hematoma or the diffuse axonal injury. Regarding diffuse axonal injury, it is a hallmark of the severe traumatic brain injury, and it is characterized by extensive generalized damage to the white matter of the brain, and it is a major cause of the prolonged coma due to disruption of ascending radicular connections to the cortex. And the torn axons, they actually retract, and they are evident histologically as the retraction walls. We can grade the diffuse axonal injury on the MRI scan. In the grade 1, so in the grade, regarding the grades of the diffuse axonal injury, in the grade 1, there is involvement of the sagittal surface of the white matter of the cerebral hemispheres, whereas in the grade 2, the involvement of the grade 1 plus and the involvement of the corpus callosum, and in the grade 3, the involvement of the grade, including the grade injury of the grade 1 and grade 2 plus a focal lesion in the cerebellopeduncle. Regarding the secondary injury, whenever there is a primary insult to the brain, either it is because of a blunt trauma or the penetrating trauma, there is an activation of the complement cascade system, and there is the initiation of your inflammatory pathway. So there is a cascade of metabolic, biochemical, and the cellular pathways, and this cascade is potentiated or exacerbated in the presence of the hypoxemia and the hypotension, and potentially leading to the decrease in the cerebral blood flow, the cerebral hypoperfusion. So when there is a decrease in the cerebral blood flow, the cerebral hypoperfusion, there is a failure of the ionic pump, and when there's a failure of the ionic pump and the membrane, cellular membrane permeability is increased, there's release of the excitatory neurotransmitters, that is glutamate and the aspartate. There is a release of the excitatory neurotransmitters, the glutamate and the aspartate, that further potentiates and this failure of the ionic pump, leading to the damage of the blood-brain barrier, and there is a mitochondrial dysfunction, impairment of the glucose metabolism, and ultimately leading to the free radical formation and the cellular death. And so at this point, the cellular membrane become very leaky, and it leads to the development of the cerebral edema, and ultimately leading to the raised intracranial pressure. These are the potentiating causes of the secondary injury. The most deleterious effect is of the hypoxemia on the brain perfusion, and it has been associated with the worst outcomes. And the other factors of the secondary, the other factors that can lead to the secondary brain injuries, that include the hypertension, hypercarbia, hyperthermia, hyperglycemia, hypoglycemia, CS, and the infection. Regarding classification of the traumatic brain injury, so why we need to classify the traumatic brain injury? This is because the greater the severity of the TBI, and the greater will be, the more worse will be the outcome, and the management is entirely different in the different classes. So the most common scale that is used to categorize or to classify the traumatic brain injury is the Glasgow Coma scale. It does help us in the initial management of the children, and it also helps us in the initial prognostication, but it doesn't tells us about the outcome later on, like post injury at 6 months or the 1 year. So the Russell and the Mississippi, they introduced these words, the post traumatic amnesia and the loss of consciousness, to classify the traumatic brain injury severity. So in the mild category, the GCS would be 13 to 15. The post-traumatic amnesia is of less than 1 day, the loss of consciousness from 0 to 13 minutes. And in the moderate category, the GCS would be 9 to 12, post-traumatic amnesia phase would be 1 to 7 days, and the loss of consciousness from the 30 minutes to 24 hours. Whereas in the severe TBI, the GCS would be in the scale of 3 to 8, and the post-traumatic amnesia more than 7 days, and loss of consciousness more than 24 hours. So I will be talking more about the severe traumatic brain injury during my next slides, how we need to manage the severe traumatic brain injury in the ICUs. We can also classify the traumatic brain injury on the basis of the morphological features on the CT scan. Regarding the CT-based classification, there are two classifications. Either we can use the Marshall scale or the Rotterdam scale. The Marshall scale is more complicated and more commonly used in the adult population to categorize the TBI. So here I will be discussing about the Rotterdam CT classification. If we number it numbers from 1 to 6, and the morphological features that we need to see on the CT scan include the basal cisterns, whether the basal cisterns are normal, they are compressed, or they are absent, and then give a number on the basis of their morphological feature from 1 to 2. Then a midline shift, whether it is present or not, and then the diameter of the midline shift, either the epidural mass lesion is present or absent, and the intraventricular hemorrhage or subarachnoid hemorrhage is present or absent. So the greater the number of the Rotterdam scale, the more worse will be the outcome. So it does help us in the prediction of the mortality after the severe TBI. Regarding the management of the severe traumatic brain injury in the pediatric population, we need to take a proper history, a proper focused physical examination, and then maintenance of airway, breathing, and circulation, and then the invasive and non-invasive monitoring, and then further the treatment. So focused history in general, we need to ask from the parents or from the attendants at what time the incident actually took place, at which place, what was the mechanism of the injury, and what was the vehicle speed in if it was a high velocity motor vehicle collision. Then any significant past medical history, any history of epilepsy, any previous history of seizures, any previous history of underlying cardiac abnormality, then the suspected influence of drugs or alcohol. This is not very important in the pediatric age groups, but it does has its importance in the adolescent age group or the adults. Then any possible medical reason for the accident, for example, during driving can have a seizure or any arrhythmia, or if there is any previous history of the spontaneous intracranial hemorrhage secondary to any congenital hematological abnormality. Then if that event was witnessed by a medical personnel and that child or the adolescent is brought up by the medical personnel, then we need to ask about these specific or the particular questions. What was the neurological state at that time? What was the level of the consciousness? What was the pupillary response at the moment of the injury, at the moment of the incident, and what were the vital parameters at the scene, and what were the parameters during the transport to emergency department. And then we need to ask about the estimated blood loss, and what treatment was given at the scene, and what was continued during the transit from that scene to the hospital emergency. And then in the physical examination, we need to carefully assess for the airway. Like if there are any secretions or any blood in the upper airway, then we need to clear it. We can manage it by the oropharyngeal airway. Then we need to examine thoroughly the neurological examination. What are the baseline sensations? What is the motor function? What are the pupils like? And what is if there is any presence of focal neurological deficit? And what is the degree of TBI? We can stratify it at that moment, whether it is falling into a category of the moderate TBI or the severe TBI. And then the careful assessment of the cervical spine injury, that is crucially important. And then if there are any critical signs of other trauma-related injuries are present, like there can be pulmonary contusion, any pneumothorax or the intra-abdominal, any visceral injury for the bleeding, the splenic fracture, or the like the bleeding in the spleen or the liver. The early assessment is important in order to identify any underlying cervical spine injury or the cervical spine fracture. So there is a strong correlation between the low GCS and the cervical spine injury. So if a patient is coming to you with a low GCS like less than 8 by 15, then there should be a high degree of suspicion for the cervical spine injury until proven otherwise. And we need to examine the tenderness along the spine, any gap or the step deformity, or any mass effect due to the edema, hematoma, or the muscle spasm. Regarding whether we need to do any radiological any radiology in these patients to rule out the cervical spine injury. So there are the two well-established guidelines for obtaining the cervical spine radiography imaging of the TBI patients. The first one is the Nexus, and the second one is the Canadian C-spine rule. The Canadian C-spine rule is basically for the adult population. So I will be discussing about the Nexus guidelines. So what these Nexus studies says that if the patient meets the low risk criteria, like there is no posterior midline cervical spine tenderness, there's no evidence of intoxication, the patient is having a normal level of alertness, there is no focal neurological deficit, there is no painful and distracting injuries, then no radiography is needed. But if it does not fit the low risk criteria, then you need to do further radiographic studies to rule to see the cervical spine injury. Then securing the airway in a patient with a traumatic brain injury is very important, and it is very difficult as well. So if we cannot do any radiographic study, and it cannot be done because of any reason like the hemodynamic instability or because of the airway emergency, then the cervical spine injury should be assumed until proven otherwise. And we need to prevent the further neurological injury. We need to stabilize the cervical spine by the cervical collar. And so the cervical collar may stabilize the spine, but it can interfere with your direct laryngoscopy. So removal of only inferior portion of cervical spine is recommended, leaving the posterior portion behind. And this is a method for stabilizing the cervical spine if we are intubating the child or in the case of putting a laryngoscopy. So one person need to maintain the cervical spine in line, that is a manual inline mobilization, and the other person is going to intubate. So after intubating the child and putting the child on the ventilator, so what should be our ventilation strategies to prevent the hypoxia and the hypercarbia? So hypoxia is a major killer in the patient with a traumatic brain injury. So this is a graph showing the relationship of the hypoxia with the cerebral blood flow and the hypercarbia with the cerebral blood flow. So when in the presence of the normal autoregulation, the cerebral blood flow is maintained over a wide range of the PaO2 from around 50 to 150. So in the traumatic brain injury, in the injured brain, this cerebral autoregulation is impaired. It is no longer maintained. So in the case of the hypoxemia, when the PaO2 levels fall below 60, it will result in the decrease in the cerebral blood flow. When the PO2's level will decrease, it will lead to increase in the cerebral blood flow level. And when the cerebral blood flow level is increased, there will be increase in the ICP. And same goes with the PaCO2's level. When there is a hypercarbia, the more PCO2 levels in the blood, it will lead to the vasodilatation in the brain, increase cerebral blood flow, and increase ICP. So our targets should be that we should maintain our saturations between 92 to 99%. PaO2 should be maintained from 90 to 100. And the PCO2 should be maintained from 35 to 40 millimeters of mercury. Regarding the PEEP, there are no specific targets for the PEEP, and these are according to the current 2019 guidelines. So according to these 2019 guidelines, there is level 2 recommendation. Level 2 recommendation is that the prophylactic severe hyperventilation to PaCO2 levels less than 30 millimeters of mercury in the initial 48 hours after the injury is not suggested. If we are using the hyperventilation in the setting of the refractory intracranial hypertension or in the setting of impending herniation, then we can do it by using the advanced neuromonitoring for evaluation of the cerebral blood flow. Then I will talk about the mechanical ventilation induced brain damage. So there is association between the pulmonary dysfunction or in the patient with acute brain injury, because of the hyper responsive of the pulmonary vasculature to the hypoxemia and the hypercarbia. So what happens is that there is this stimulation when there is the acute traumatic brain injury, and there is a stimulation of the mechanoreceptors and the chemoreceptors and the lungs, and there is also the inflammatory process that will lead to these three pathways: the humoral pathway, the neural pathway, and the cellular pathway. So by the monocytes and the macrophages, these inflammatory mediators are released like interleukin-6, TNF-alpha, and the interleukin-1 beta, and they reach these inflammatory mediators, they reach the brain, and they cause the release of the prostaglandin E2 and nitric oxide that lead to the cerebral vasodilatation and increase in the cerebral blood flow, further exacerbating the increased cerebral blood flow. Similarly, there is also why the neural pathway, the vagus nerve is stimulated, and from the TNF-alpha pathway, there is a protein that is MCP1 in the brain that is stimulated, and this MCP1 protein, that is a monocyte chemotactic protein 1, and this protein is activated, and this protein further leads to the generation of the inflammatory mediators by the monocytes and the macrophages, and thus further leading to the exacerbation of the neuroinflammation. When we are dealing a child with a severe TBI, with a severe ARDS, um, it is very it becomes very crucial to both treat the TBI with the severe ARDS, and the ARDS and is common. It is common in the neurocritical care patients and associated with if there is ARDS with the TBI, then it is associated with the worse outcome and the longer ICU length of the stay. So when there is a concomitance of the TBI and ARDS, the ventilatory management can be very challenging, as the ventilatory targets are often in the conflict in these two pathologies. So when we are ventilating a child with underlying traumatic brain injury with the tidal volumes of more than 10 ml per kilos, it has been associated with the development of the ARDS. So how we need to monitor these kids like TBI with the severe ARDS. And the TBI, we need to maintain the PO2s in the levels between the 60 to 80, whereas in the ARDS, there is a permissive hypoxemia, like 58 to 88 millimeters of mercury. So it is suggested that if we are if we are dealing a child with a severe TBI and the severe ARDS, then we need to adjust these parameters according to the underlying pathology, and by using the advanced neuromonitoring techniques like the brain tissue oxygen tension monitoring in order to manage these kids with the TBI with the ARDS. Similarly, the PCO2 levels, like in the case of the TBI, as I have already mentioned, that it should be maintained between 35 to 45 millimeters of mercury, whereas in the case of the ARDS, we allow the permissive hypercapnia, so there will be the more PaCO2s leading to the cerebral vasodilatation. So it is said that it should be targeted case to case according to the like every case to case, the PaCO2 levels should be targeted and with the advanced neuromonitoring, and same is for the PEEP. And it has been shown that by increasing the PEEP, the intracranial pressure is increased. Obviously, the cerebral venous return will be reduced, and there will be the accumulation of the more CSF in the brain and leading to further deterioration of the raised ICP. But the studies have shown that if you maintain the MAP either by your intravascular volume or by using the vasopressors, then you can increase the PEEP in these patients of severe TBI with the ARDS. The blood pressure should be below 30 centimeters of water in both the TBI and ARDS. Regarding the prone positioning and the recruitment maneuvers, they can also be done in both the situations, but with the careful, advanced, strict neuromonitoring. Then the use of the analgesia and sedation in order to provide the comfort and relieve the anxiety and to synchronize the patient with the ventilator. We are usually using the analgesia and the sedation. So it is recommended the combination of the benzodiazepine or the opioid. In the benzodiazepines, we can use the midazolam, and in the opioids, we can use the morphine and the fentanyl. And it is said that you should avoid the bolus of midazolam or the fentanyl during the acute increase in the intracranial pressure. And the propofol infusion is no longer recommended either for the sedation or the management of the intracranial hypertension. Regarding the neuromuscular blocking agent, there is no recommendation for use of a neuromuscular blocking agent in patients with a severe TBI, except that if you are using it for the rapid sequence intubation, or if there is an acute severe lung injury in association with the patients of the TBI, then we can use the neuromuscular blocking agents. It can be, although the specific, it depends upon the specific indication, the choice and dosing of analgesics, sedatives, and neuromuscular blocking agents. It should be left to the treating physician. Now, regarding the neuromonitoring, what are the advanced, what we need to monitor in these patients with the severe TBI? We need to monitor the intracranial pressure, the cerebral perfusion pressure. Then we have to do we can monitor it by the neuroimaging like the CT scan or the MRI, and then advanced neuromonitoring techniques. So ICP monitoring, it can be done via the two modes. Either it can be used, ICP monitoring can be done either via the invasive modes or the non-invasively we can monitor the ICP. Regarding the invasive modes of ICP monitoring, we can put an intracranial board. It can be, there are the different types, whether it can be inserted intraventricular or intraparenchymal, subarachnoid, or the epidural. So the current recommendations are that we can use the invasive ICP monitoring, although it is a level 3-1 indication. There are no class 1 or class 2 studies to recommend and that you should use invasive modes of the ICP for monitoring the intracranial hypertension. Then regarding the non-invasive modes of ICP monitoring, we can monitor the ICP on the bedside non-invasively. So in the 1970s, the interior fontanel pressure was actually measured by the fontometer to determine the intracranial pressure, but now it is not widely used. We can use the optic nerve sheath measurement to find out any associated intracranial hypertension or the transcranial Doppler ultrasound, or it is a non-invasive bedside technique that can actually measure the cerebral blood flow by measuring the velocity in the middle cerebral artery. And then there is a non-invasive technique that is the near infrared spectroscopy. It can also measure the brain tissue oxygenation non-invasively. It has a more role in the cardiac surgeries, but it can also be used for the ICP monitoring in the patients with the TBI. So regarding the thresholds for the treatment of intracranial hypertension, what should be a safe limit of the ICP? So it is a level 3 recommendation that targeting the ICP at a threshold of less than 20 millimeter is suggested. And if there is a sustained increase of greater than or equal to 20 millimeters of mercury for greater than or equal to 5 minutes, it needs treatment and monitoring. Regarding cerebral perfusion pressure monitoring, it is a product of MAP and ICP. So this figure shows that under the normal, like when the brain is not uninjured brain, there is a maintenance of the cerebral blood flow over a wide range of the cerebral perfusion pressure. But when in the injured brain, the cerebral autoregulation is disturbed. So there will be there is a very narrow range in which we need to maintain the cerebral perfusion pressure. So the key controversial issues are that what should be the minimum level for the cerebral perfusion pressure that is adequate, and does increasing the cerebral perfusion beyond the level provides adequate perfusion of the brain, or it would either it would have an additional beneficial therapeutic effect or it will have a detrimental effect. It is not known. In the injured brain, it's basically the metabolic activity is decreased. So we do not know, maybe the brain is having, because of the low demand, so the low normal cerebral blood flow can be the normal for the cerebral perfusion pressure. So it is a level 3 recommendation that you should maintain, and you should maintain the cerebral perfusion pressure at a minimum level of 40 millimeters of mercury. Like minimum cutoff is 40 millimeters of mercury. It should not be beyond 40. Or it is the predefined CPP thresholds by the age are 40 to 30 for the 0 to 5 years, and 50 to 35 from 6 to 11 years. Sorry, my slide is stuck. It's not changing. So we should be aiming the blood pressures. Systolic blood pressure greater than 70 plus 2 into age and years. And regarding the MAP, there is no consensus like how what should be the value of the MAP for maintaining the particular cerebral perfusion pressure. It varies. Like it can be in the different studies. It is different. There is no consensus over the map, and it is said that it should be maintained at the normal levels at the 50th centile. And the different studies, it was maintained more than, and it was its value is recommended in the different studies in the different value. Like in the some studies, it is said that it should be maintained more than 90 millimeters of mercury, and whereas in some other studies, it said that it should be between 120 to 130 millimeters of mercury. However, it should be the minimum should be the 50th centile according to the age. Regarding the neuroimaging, the CT head is the current preferred imaging for the rapid detection of the intracranial injury, any signs of the mass effect or the cerebral edema for the trauma victims with the severe TBI. And acute CT imaging is universally performed in the high-income countries during the initial evaluation and detection of intracranial injury. So it is a level 2 recommendation that excluding the possibility of the elevated ICP on the basis of the normal initial, like if the CT scan is performed in the initial hours after injury, like in the first 0 to 6 hours after injury, the CT examination of the brain, it is not suggested in the comatose pediatric patients. And routinely obtaining a repeat CT scan greater than 24 hours after the intervention, unless there is any acute deterioration of any acute neurological deterioration, or there is an increasing ICP. Regarding advanced neuro monitoring, there are the 3 ways to monitor the cerebral perfusion pressure and the cerebral oxygenation. That is the brain tissue oxygen tension monitoring, and the jugular venous saturation monitoring, and the cerebral microdialysis. Regarding brain tissue oxygen tension monitoring, basically a catheter is inserted into the brain parenchyma that measures the oxygen level in the brain parenchyma, and this oxygen tension, it depends upon the oxygen delivery, the oxygen consumption. So it is recommended that it should be this brain tissue oxygen level, it should be maintained more than 10 millimeters of mercury if we are using this for monitoring the cerebral perfusion pressures and cerebral oxygenation. And it has been found that a threshold of 10 millimeters of mercury was associated with decrease in cerebral blood flow levels, leading to ischemia, the mitochondrial dysfunction and derangement in the cerebral metabolism. And the value of 0 millimeters of mercury, with a persistent value of 0, it was associated with the brain death, whereas values in the range of 10 to 20 millimeters of mercury, the brain tissue was at risk for the secondary injury. So it is a level 3 recommendation that if we are using the brain tissue oxygen tension monitoring, then its value should be more than or equal to 10 millimeters of mercury. Then another modality in the advanced neuromonitoring is the jugular venous saturation monitoring. Regarding the pediatric literature, the pediatric literature is limited for this one, and it has been found out that the 2 or the more episodes of the STVO2 below 50% that was associated with the poor outcome. So it should be maintained between the 50 to 70%, 55 to 70% is the cutoff value for this tubular venous saturation. And although the exact normal ranges are yet to be established. And then how we can maintain the normal intravascular volume status. These children should be kept in the euvolemia state, not in the dehydrated or the hypervolemic state. So we can achieve this target via CVP monitoring. The CVP should be maintained between 8 to 10 millimeters of mercury. Then we can use the other markers of the perfusion, like the urine output, serum creatinine level, and then your clinical examination, like how are the pulses and the perfusion. And we need to maintain the serum sodium level between 140 to 150 millimeters of mercury. The blood sugars should be maintained between 100 to 198, and it is recommended that if the blood sugar goes beyond 198 millimeters of mercury on the 2 consecutive phases, then you should start the insulin infusion. Regarding the fluid management, like what type of fluid should be used, what should be the fluid balance, and whether we should use the dextrose or not. So it is said that you should target the normobulimia, use 75% of the maintenance fluids to start with, and start with the normal saline in the older children and the adolescents, and in the younger kids, you can add the 5% dextrose in your maintenance fluids. Regarding hyperosmolar therapy, in order to treat intracranial hypertension, there are two agents used as an hyperosmolar agents like the mannitol and the hypertonic saline. They both decrease the cerebral edema and the both decrease the ICP, but which one is preferred over the other? There are no such consensus. So it is a level 2 recommendation that the bolus 3% hypertonic saline is recommended in patients with intracranial hypertension with the dose range between 2 and 5 millimeters of mercury over 10 to 20 minutes. And it is a level 3 recommendation is that you can use the continuous infusion of hypertonic saline with the values between 0.1 to 1 millimeters of 1 ml per kg per body weight. And so our target should be to maintain the ICP level below 20 millimeters of mercury. In the case of the impending herniation, or if there is a refractory intracranial hypertension not responding to other therapy, then we can use the bolus of, it is a level 3-2 recommendation that we can use a bolus of 23.4% hypertonic saline, and the suggested dose is 0.5 ml per kilo with a max dose of 30 ml. Regarding maintenance of the temperature, it is now recommended that the temperature should be maintained in the normal range. Neither hypothermia nor hyperthermia, both are dangerous for the injured brain. So it is a level 2 recommendation that to improve the overall outcome, the prophylactic hypothermia, that is 32 to 33 degrees centigrade, it is not recommended. Like the early prophylactic hypothermia is not recommended to improve the outcomes in the patients with intracranial hypertension. We can use the late moderate hypothermia of around 32 to 33 degrees centigrade when there is a refractory intracranial hypertension. So the early hypothermia induction that was, in the studies, it was shown that the early hypothermia induction that was associated with the worst outcomes in the form of the severe disability, the vegetative state, and death. Regarding the CF prophylaxis, the prophylactic treatment is suggested to reduce the occurrence of the early post-traumatic seizures, like within the 7 days. There is insufficient evidence to recommend any preferred drug like levetiracetam over the phenytoin. There is no such evidence to support which one is superior over the other. Both can be used, and if you are using the SAYES, then and the use of continuous EEG monitoring is suggested, especially if you are using the neuromuscular blocking agent. So far now we were discussing about the first types of the therapy or the intracranial hypertension. Now, if the patient is not responding to your first tier therapy, your first medical therapy, and there is still intracranial hypertension, ICP level is more than 20 millimeters of mercury, then we can repeat the CT scan. And if on the CT scan, if there is a new or expanding surgical lesion and the surgery is indicated, then we can do either, if there is a mass, then that mass can be removed, or if there is a midline shift or any generalized diffuse cerebral edema, then we can do the decompressive craniectomy. Or if there is no any indication of surgery, then we can use the barbiturate, infusion barbiturate, the late moderate hypothermia of 32 to 34 degrees centigrade, and the hyperventilation from 28 to 34 millimeters of mercury in the settings of refractory intracranial hypertension or the impending herniation, and the high levels of osmolar therapy like bolus of 23.4% normal saline, hypertonic saline. And then these are the different signs and symptoms, and we can detect on our clinical examination whether the patient is having an impending or the ongoing herniation. In the transtentorial herniation, there can be a pupillary dilatation with the bradycardia. And the foramen magnum herniation, there can be nystagmus, bradypnea, bradycardia, or the hypertension. And in the subfalcine herniation, there can be the unilateral or the bilateral weakness. If any of these signs are present, consider it as a medical emergency. Hyperventilate the child with the PCO2 levels of less than between 28 to 35, and hyperventilate with the FiO2 100% administration of mannitol or hypertonic saline. And if the EVD is functional, then we can open it for the continuous drainage. Urgent CT scan brain is done and get a neurosurgical review. Regarding cerebrospinal fluid drainage, it can be done either prophylactically or therapeutically. It can be done either to monitor the ICP or to decrease. It can be either used alone to monitor the ICP, or it can be used as a therapeutically to decrease the intracranial pressure. So it is a level 3 recommendation that you can use a CSF drainage via EVD to manage increased ICP in the pediatric population. So it is suggested that you should use the continuous CSF drainage rather than the intermittent CSF drainage. We can use it by the EVD or the lumbar drain. Then regarding the decompressive craniectomy, if there is a refractory intracranial hypertension or if there is a impending herniation, then the decompressive craniectomy is suggested to treat that. And now the question arises, what either the bilateral frontotemporal decompressive craniectomy is more better, or a small one is better, or early or the later one. So it has been shown that the early decompressive bilateral frontotemporal craniectomy, that has been associated with a decrease in the intracranial pressure, and it will improve the it will decrease intracranial pressure for that moment. But if we see the outcomes later on, then it is not associated with the very good outcomes. It was associated with the bad outcomes. So just to review the updated recommendations, these were the previous recommendations according to the 2014 guidelines. So the new one is that for the monitoring, we should be using for the monitoring, we can use this neuroimaging, and so excluding the possibility of elevated ICP on the basis of normal initial CT examination of the brain is not suggested in the comatose pediatric populations. And routinely obtaining a CT scan more than 24 hours after the admission and initial follow-up is not suggested for decisions about neurosurgical intervention, unless there is an acute deterioration. Same for the thresholds. So the bolus of 23.4% hypertonic saline is suggested for the refractory intracranial hypertension. And for the ICP control with the use of the multiple ICP related therapies, as well as appropriate use of analgesia and sedation, avoid bolus administration of midazolam and of fentanyl during ICP crisis due to the risk of the cerebral hypoperfusion. Regarding severe prophylaxis, the prophylactic treatment is suggested to reduce the incidence of early post-traumatic seizures, and to improve the overall outcome, the prophylactic moderate hypothermia is not recommended in the initial stages, and if, we can use it in the later stages for the refractory intracranial hypertension. Same with the, so regarding the nutrition, it is a level 3 recommendation, like in order to improve the overall outcomes, we should start the early nutritional support within 72 hours to decrease the mortality and improve the outcome. Regarding the corticosteroids, the use of steroids is not suggested to improve outcome or reduce the ICP. So this is a cerebral perfusion pathway. So when the ICP is, so even we are targeting our ICP pathway or the CPP pathway or the brain tissue oxygen tension monitoring pathway, so we need to maintain the cerebral, we need to, we cannot take as a single measure for the appropriate neuroprotective measures. We need to take all these pathways in conjunction. So often when the ICP is increased, the CPP can still be maintained, and the literature supports the maintenance of a minimum value of 40 millimeters of mercury, and the age-specific thresholds of 40 to 50 millimeters of mercury with the infants at the lower point, and the adolescents at the upper point. These are the minimum acceptable values, and the high values may be needed to prevent patients from at risk of falling. Then ensure the appropriate intravascular volume with an adequate CVP, and interventions targeting. So if we are only targeting the ICP, so the interventions that we are doing, they can improve the cerebral perfusion pressure. For example, the treating increased ICP with a bolus of hypertonic saline that is associated with improvement in both the intracranial pressure and the cerebral perfusion pressure, while the administration of fentanyl or the barbiturates, they will only cause a decrease in the ICP without improving the cerebral perfusion pressure. So implicit in the CPP pathway is the practice of tolerating the mild intracranial hypertension in the presence of adequate cerebral perfusion pressure. But there is an insufficient evidence to strongly prioritize between these two alternative approaches. And then when we need to wean these therapies. So at any time along the treatment pathways, when the ICP, CPP, and your brain tissue oxygen pressure monitoring, if you are using, they are normalized and they remain stable for around 12 to 24 hours, then consideration should be given to carefully withdrawing interventions targeting these parameters. And these interventions are withdrawn in the reverse order of their application, and the prior severity of the intracranial hypertension can also influence the withdrawal of the therapies, as can toxicity from a given therapy. So the neurological examination, the focused and the repeated neurological examination is very important, and it helps us guide the withdrawal of the therapies or the monitoring, particularly when the treatment intensity level is low. So how we can prevent the risk of the trivia in the children? How can we reduce it? By using a child safety seat or seat belt when the child is in a motor vehicle, or make sure the child wears a helmet when riding a bicycle or playing the sports like hockey or football, and avoid shaking baby in order to prevent the shaken baby syndrome. These are my references, and thank you. Thanks to my faculty, Dr. Naveed and Dr. Siddhar Saab, for guiding me and facilitating me for this presentation. And any questions?
Thank you, Nazia. I think this was a very comprehensive and elaborate overview. You took us on a journey starting right from the pathobiology, pathophysiology of traumatic brain injury, right through the monitoring, and I think presenting evidence-based medicine. So just to mention to our audience here, so all the evidence that Nazia has shared here are from the latest 2019 guidelines of severe TBI, and you can access them online. And this is from Patrick Kohenig's group. So I would now open the floor to our judges and panelists for sharing their comments and suggestions. And we'll start off by taking questions if we have. So dear judges, if you could, if possible, if we could have you on video, or you could share your comments, and if you have any questions, so we would start off with you.
Yes, Assalamu alaikum everyone, it's Dr. Ataullah. Thank you very much, Dr. Nazia. A very elaborate presentation. Look, it was a, it's a long topic, but you covered most of the aspects. And the evidence was also recent. You presented it from the recent literature. Slide clarity was good, and you presented well on time. So brief and crisp. So overall, it's a very good presentation. Anyone else?
So much,
Thank you, Dr. Ataullah. Would you do you have any questions for Nazia?
Yeah, actually, we have a few questions. So should we start it by, like, from the start one by one, or?
I think
Yes,
so. We
I
can
think
take the
so.
judges' comments,
Yes.
and then we can. I think so. Dr. Shanaz is on. Dr. Shanaz wanted to speak. I have unmute her. So
Assalamu alaikum, Dr. Naz.
Okay, so now it's unmuted. So excellent presentation, Nazia. I think it was like a journey going from the beginning to the end. Very extensive. I have lots of questions, but I think I'll ask them at the end. My only, I think I'll leave the questions for the other questions that have been put forward to be asked before I start mine. So maybe, Naveed, you can ask the questions that have been given on the chat, and then we can, I think we can, I can take it from there.
All right, I think so. Do anyone else? Dr. Gahar Javed is also online. Dr. Gahar, do you want to comment?
Yes, sure. Thank you very much, Dr. Naveed, for asking my input. First of all, a fantastic presentation. I really enjoyed it. And there were a few things which I think could have been discussed. Like, for example, I'm sorry, you may be hearing a voice of traffic because right now I'm driving. So that's why I cannot come on video.
No, that's really fine.
So there is a particular category which is called NAT, non-accidental trauma, and which is a major cause of head trauma in infants. And I think we need to talk a little bit on NAT also, because that needs to be recognized by the person who is attending the head injury and needs to be treated. And it also carries some medical legal importance. The other things, the decompressive cranectomy part was good. And now there are well-defined indications for decompressive cranectomy in children, especially in young children, infants and preschoolers. And the monitoring part was also very good. Are we doing this kind of invasive monitoring nowadays in the institutions, in our institutions? I don't know. At least I haven't seen this invasive monitoring over here. I don't know what's the experience of my other colleagues. So thank you very much. It was a very good presentation.
Thank you very much, Dr. Gahar. And definitely you have correctly identified that now one of the most important part of those patients who present to us are the non-accidental trauma. Definitely these are the ones that needs to be looked into as well. Thank you very much for, do we have Dr. Wasim as well online? If he can give his comments and any.
Yes, Dr. Wasim has already shared. Yeah, so he's actually lauded Nazia. He says it's a complex topic, and each topic itself deserves a lecture. And he congratulates us and Nazia for the comprehensive evidence-based presentation. So I think we can.
I think so. We can now start with the questions. So for the question and answer, what we usually do, we will ask our judges and panelists as well to chip in, and if they wanted to answer any question or if they wanted to add anything on these question and answer session. We don't rely mainly on the fellows for that, and if the fellow can answer it as well, Nasia can answer it. That is, she is also she can also do that. So going on with the first question, one of the Dr. Amir Ahmed Malik have asked the utility of 4-score in the TBI.
When we are actually the most, actually I have discussed the severe TBI patients. So if the patient is GCS is less than 8/15, so most probably he would be ventilated. So in the ventilated patients, the more score is the 4-score. We can actually utilize this 4-score for the it is preferred score as on the GCS. Like we can use is for the our
Okay,
Sorry.
no, that's totally fine. Do we have any other comments from the other intensivists who are online, if they wanted to add?
Like if we are in the GC score, there are the limitations and there is interpersonal variation. But in the four score, basically we can use the brainstem reflexes. So we can actually use the four score on the as a preference over the GCS score in the patients with the TBI and ventilated patients.
All right, and I have correctly mentioned that it gives a lot of information apart from the GCS, TCS, especially in those patients who are being intubated. You cannot give them a full GCS score, as you can't do the verbal in them as well as if they are sedated. Uh, the most important thing in the in the four score is the brainstem reflexes, which are being the part of four score, and then you can have more information about the patient status, even if they are sedated and ventilated. The only drawback of the four score is that some of the centers, they are not using it because it does include cough and gag as a part of its scoring. And if you are doing a cough and gag in a patient who has a raised ICP, and if you are going to do it in those patients, that will going to give you a good high spike of ICP, raised ICP in these patients. And that's the reason why some of the centers are reluctant to do that, and they don't do it, especially in those patients who have raised ICP and they are under strict monitoring. So otherwise, it's a very good score to use, and definitely can be used. So do we have other questions if you have it on chat box?
They have one
Yes, Dr.
question,
Naveed.
Ravi.
Yes. Yes, Dr.
The
Nas, please go ahead.
Yes,
biomarkers.
Dr. Shah.
So the biomarkers, they have a question. I think Dr. Shahzad asked about the biomarkers. Maybe
Yeah.
you can answer that.
Yeah, for the biomarkers, there are specific biomarkers which are being used not only for the severe TBI, but mainly from the neurological injury point of view. And these are mainly commonly used are the glial fibrillary acidic protein, which is TFAB, S100B, as well as another one is UCHL1. There are other biomarkers, but they are not that commonly used. These are the blood biomarkers which are commonly used. For the CSF biomarkers, and they are using it in the microdialysis. And I don't remember, there are some CSF lactate versus pyruvate ratio and other things that gives an input how the things are. But I don't remember the exact ratio of these in the cerebral microdialysis and what the ratios are. Otherwise, uh, for the blood biomarkers, they are easy to do. They can be done, and they give. These are the non-invasive tests which we can use in these patients, especially who are presenting to us with the severe traumatic brain injury. Did anyone else wanted to add anything? If anyone else in the group, especially Dr. Humera Kalab or Dr. Mar, Dr. Wasim.
I think
So
just a
yes,
comment.
you're right. Uh, Regarding the lactate pyruvate ratio, they give the indirect indicators of onset of ischemia and the other levels like glutamate and then S SN90 or SN100, I don't remember properly, S100B or NSE.
S100B.
They can be these biomarkers can also be measured and they are indicator for the neurological outcome, but in our setup these are all not available.
And also, just to mention as a comment that the biomarkers, I think in an answer to Shazad's question, are still not the standard of care, or they're not part of any guideline. Correct me if I'm wrong. So they're still pretty much ancillary in addition to your clinical exam and whatever Nazi has discussed. But as far as the recommendations are concerned, so they're still not in, because of course a lot of places may actually not have them available. So yes, there's a lot of work being done on biomarkers. they can be used. And a lot of this is more of prognostication than anything. But if you're talking about treatment, so I don't think that we're using biomarkers to treat TBI as such. So if we may have input from our panelists on the group, if anybody else would like to add to this.
Hi, Dr. Shanaz. Yeah, Dr. Shanaz, she's mute, so I will see if I can.
Yeah, thank you. So the biomarkers are an interesting concept, especially if the blood-brain barrier has been breached. The question is, would you do things differently if the biomarkers are high, and would you consider them to be so since they are also prognostic for a bad neurological outcome, would you be willing to go and do everything despite the high biomarkers? So those are very ethical questions also. And as far as the glial fibrillary proteins and the SP100 are concerned, I guess if we talk to the lab, we might be able to do it. But you'll have to do the CSF as well as the blood. And whether in a traumatic brain injury, you would really be wanting to maneuver the child or the individual to get the lumbar puncture done, or you'll have to put in an EVD for that, and that would reduce the pressures. So it's a difficult decision to do that. But my question again is the same: in how many patients in TBI have we really put in? Do we do the intracranial monitoring besides the non-invasive one of the optic nerve sheath? I think that's the only one that is regularly being done. And also the specificity and the sensitivity of the optic nerve sheath, because would the neurosurgeon do anything if there is no change in the optic nerve sheath despite you doing it? And what is the time frame? How long would you be waiting for? Because we don't do those intracranial monitoring realistically, and so when would a neurosurgeon really should be pushed to do something?
I think so. That's a really great question, and there is a gray area behind it, and that's the reason why it has been recommended that if the patient has presented with the severe traumatic brain injury, it has been recommended to do the invasive intracranial pressure monitoring. Although we don't have it, we used to have it in an intracranial board that we usually do, and we were doing it in many of our patients when we do have it. But and now we are utilizing optic nerve sheet as well. As I remember, Dr. Gohar Javed responded quite well to the optic nerve sheet as well, and there is a good uh, uh, the neurosurgeons are becoming aware of it as well, and they do take it seriously for the optic nerve sheet. Any optic nerve sheet more than 5.5 or around 6, and they do it. They do take it quite seriously, and they do respond to it uh, 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 urgently. And we usually do it. We usually do optic nerve sheet in our setting. Uh, Almost twice daily or thrice daily if we are suspecting raised ICP in our patients. And unfortunately, we don't have, we used to have intracranial bolt, but now we don't have it due to some reasons. But at least we usually do non-invasive monitoring to guide our management, how the things are. Do we have any other comments? If Dr. Gohar Javed wanted to add anything regarding the intracranial monitoring, when it should be used in severe TBI patients. I think so. We need to unmute him if he wanted to add.
Yes, so invasive intracranial monitoring is of value in moderate to severe head injuries. Another important another important segment of TBI in kids is mild head injury. And I think we have not discussed that. Mild head injury has its own consequences. But as far as intracranial monitoring is concerned, invasive monitoring, yes, it has its own indication. Now the indications are very well defined, and it's a part of practice, standard practice. And there is significant data on optic nerve sheath correlation with the ICP. And I think the more it is being practiced, the more it is being at some point of time. I hope it will be incorporated in the practice, in the standard practice.
I totally agree, Dr. Ghautavid, and we have done it in we have done optic nerve sheet in a small case series in our setup as well. Although the patients were small, but we were being able to find out threshold of 5.5, around 5 and 5.5 for children as well as in adolescent, with good with good sensitivity, at least not specificity but good sensitivity. So yes.
So in adults, the criteria are very well defined of indications of ICP monitoring and decisions based upon those ICP monitoring results. But in kids, still the data is not that much well defined as compared to adults.
So if you consider the new guidelines, they have actually divided it in terms of monitoring. If you have an invasive ICP monitoring from the beginning, there is a separate, you go separately. Then if you have uh, brain microdialysis or more advanced imaging, then you have a separate tool, as well as if you have non-invasive monitoring, you don't have invasive monitoring, then you go separately. So they have well defined the areas on how, if you don't have these things, then how to go about it. But it is now recommended that every severe traumatic brain injury should get the ICP monitoring. That's a standard of care in the US.
Naveed, I agree with you, and I'm kind of wondering because I have seen the bolt being put in. So maybe Dr. Gohar or Shazad can answer whether why is it non-functional? Is there some problem with that, or do we need to sort of each time? Is it a new apparatus that is put in, or is it sort of reused, something like that? And or is there a risk of infection which is higher? So why? What happened?
I think I will see if Dr. Gohar can answer that.
Dr. Gohar, sorry, can you hear me?
Yes, I can hear you.
So, Dr. Gohar, the bolt, is it not available now for the intracranial pressure monitoring? Because
yes, it is not available nowadays. And efforts are being made to make it available again, but right now it's not available.
So is it like every time is it a new sort of a piece that you have to put in, or is it like a new piece, or is it reusable?
The connections are reusable, but the piece which is put inside has to be disposable.
New one. Okay. All right. So those are not available.
Those are not available. Yes.
Okay. And is it separate for pediatric? The age group? Is this a size? Is it size?
It's not separate for pediatric. Like it's not. No, it's not.
One standard.
Yes.
Yeah.
Okay.
It's intraparenchymal type of ICV bolt.
So can we in these conditions think about putting in an EVD? Would that be helpful to us?
Unfortunately, the ventricles are very small in most of the cases of acute head injury. They are either shifted or the brain is so swollen that they are very small, and it's not easy to put in the EVD. So it's not really practicable, very practicable in cases of acute head injury. The ICV bolt is easy to put in, and in most of the cases, the ICP that it shows, it reflects the intracranial pressure very correctly. So I think the ease of putting it in and ease of monitoring both make it a very good tool to be used.
Okay. So I think in that situation, I think the Department of Pediatrics should, put pressure and procure these. I think this is important for the ICP because we see head injuries quite frequently in pediatrics.
Yeah.
So,
Dr. Naveed, I have a question.
Yeah.
We don't have, the ICP monitor in our institute. So, have we ever tried, like, if the patient, because in some cases we put the EVD, so can we connect it to, like, the CVP monitor and
Yeah,
measure
for
the
sure.
pressure from
For
there?
sure.
Have you tried
Definitely.
it, like, in your
Definitely.
EVD
This
is the
is
best form of
EVD.
ICP monitor.
Yeah.
EVD is the best form of ICP monitor. In fact, the other ICP monitors are standardized based upon the EVD. So it is the standard ICP monitoring device, intraventricular catheter connected to an ICP monitor.
no,
And
not connected to
you don't.
ICP?
Yeah. You don't need
If I don't
a
have an
separate.
ICP, yeah.
Yes, you don't need a
You,
separate ICP monitor. You need to connect it to the transducer, and the same way you were going to transduce it for the CVP, you need to just keep it around the triggers level, and then you can monitor the ICP in those children. And
Well,
you can
Dr. Naveed, I
even
tried
follow
it
the
couple of
waveform.
times.
You can
I
even follow
tried
the
it couple
waveform
of
also.
times. Okay, but it, like, it was coming always in negative. I don't know, for some reason. Maybe it was not
It might not be.
zero, or maybe
Yeah, that
mm-hmm.
might be the problem, that it might not be zeroed. But I think so. That's Dr. Gohar Javed has mentioned. Even in when I was in SICKIT, and we used to, whenever we have a EVD, we used to keep it under monitoring whenever it is closed. So closed doesn't mean that you can't monitor the EVD, but you can transduce it in on your monitor as you do it for the CVP, as well as for the arterial lines as well. And you can easily monitor with the same kit which you use it for the CVP monitoring.
Okay.
Yeah.
Can you hear me?
Khalab has raised his hand. So Khalab, can you add anything?
So thank you, and I think this is a nice, exciting discussion. But I'll just like to draw your attention to a couple of things that this is all very nice discussion and the standard of care. But the problem with monitoring invasive intracranial pressure is then there are again two approaches. One approach says that you go and treat the intracranial pressure. The other approach says that you go and treat or manage the cerebral perfusion pressure. So my thing is that I believe, and majority of the participants who are joining this call are from centers where this facility is not available. So I would say that yes, if you can have this intracranial pressure monitoring, that's best. But if you cannot have, that's perfectly fine. You can still manage patients with traumatic brain injury. The principle is that you just stick to the basic things which Nazia discussed. So if you do that well, you keep the blood pressures on the correctly. You treat the coagulopathy and hypoglycemia, ventilation, etc. And all those principles, you can manage these patients well. We should not wait for all these things to come and then start thinking कि हम manage कर सकते हैं या नहीं कर सकते. So I think this is one thing. And second thing is, yes, EVD is good for ICP monitoring, but the problem with EVD is that most of the time when we get an EVD, our purpose is to drain the CSF. And then so we don't have that all fancy stuff कि हम उसको monitor भी करें and साथ साथ it's on the drainage so that is solved. And then there is also a greater risk of infection if you try to keep it long. So all these things should be kept in mind when we are discussing this. Thank you.
So, Khalaf, that's a great point that we need to use it in our culture whenever we have an EVD. It's just like a CVP monitoring that the fluids are going on and CVP is not being measured. But if you can do it every 4 hourly or 6 hourly, it's just that you have to attach it with the EVD where the EVD is being drained, and you have to just there is a three-way in it. You need to just push the three-way toward that side, and you will get the reading within a few seconds, and then you can open it back again if you wanted to keep it under continuous monitoring. So there is one thing that we need to bring it in our culture. If we have an EVD, we should do these ICP monitoring in these children, that we don't usually do that. The other thing, that's a great point of discussion about the ICP and cerebral perfusion pressure. Uh, that's an area of discussion in most of the TBI meetings as well as in TBI discussion nowadays. And the thing is that you need to take the patient as a whole. You need to lower down your ICP to the lower than 20. That's the baseline. And the other thing about the cerebral perfusion pressure, it has been seen that even if you are maintaining the cerebral perfusion pressure and but your ICP is on the higher side, these patients do herniate. So it's important to take the patient as a whole and then uh, get the ICP down. Uh, so still the question is still open, and there is no uh, strict evidence, or it is not black and white that what to monitor or what not. There is a gray area in these areas, and one need to take the patient as a whole when treating the patient with ICP or cerebral perfusion or considering cerebral perfusion pressure. Uh,
Naveed, I have a question. May
yeah.
sound silly, but when we are treating premature babies, we are
Mhm,
very careful with noise, sound,
mhm.
suctioning because of their
Yeah.
friable germinal matrix and their
All right.
intraventricular hemorrhage. So
All
when
right.
you said that the force core cannot be used because of the gag that you need to check, and then that
Mhm,
increases the intracranial pressure, my question is, should we be considering whether we need to keep them separately in a room, which is less stimulatory, uh,
mhm,
do less maneuvers on these individuals, move their head and neck less, less suctioning, and minimal handling, because that would, every time you handle, the pressure would go up. So this is very similar to what you would be doing with a very premature small footed baby and trying to prevent neuronal injury. So my question is, would that be something that we can consider also as part of our management? Because the TBIs are not kept separately; they are kept in a
mhm.
probably in a combined room, and we don't even think about the nursing care, which is should be also strictly regulated,
I think
because
so,
the pressures
Dr.
will go
Shanaz.
up and
Yeah,
down.
yeah. I think so, Dr. Shanaz. That's really a great point, and that is that we don't usually put into account, even in the in best of the best centers. They are not looking into it as well. But as a generalized care, yes, definitely these things do account for development of significant brain insults, as these patients do usually have delirium as well as issues of uh, delirium associated either with these because so but these areas are not being looked into so far in the it has been seen in neonates as well as in preterms, and they are using noise signals parameters in the NICU especially, and they usually take care of it. I remember that when I went to the NICU in sick kids, there was a noise parameter, and uh, whenever there is a frequency of noise is slightly higher, it goes red, and then the nurses will tell us now to leave the unit. So definitely uh, it needs to be looked into, and I do believe that it has an impact on the children, but it has not been looked into that as that it has been looked into in the preterm as well as in the neonates. Uh, and that's an area which is which we don't have any evidence so far. And that's a great point, I think, Dr. Shanaz has made. So another question to Nazia as well as to the others. What medications now you would like to consider in a patient with severe TBI if you wanted, if these patients presented to you in the emergency department with considerable raised ICP with low GCS, and as these are potential physiologically difficult airway, what medications you will going to use, how will you proceed with it, and what are the things? Because if you were not going to proceed in a cautious manner, you might induce herniation in these patients.
Okay, so as I have already mentioned in my presentation that when the patients present with a low GCS, they can be associated cervical spine injury. So first of all, we need to keep the patient in the manual in line, and then we try to intubate the child and secure the airway. So regarding the drugs, first of all, we will use we use the analgesia, sedation, and the neuromuscular blocking agent for the RSI. So in these patients, in order to reduce the intracranial pressure and blunt the reflexes, we use the adjunct medication like the lidocaine, 1 mg per kg we use, and then we intubate the child by using the analgesia. We can use morphine. Previously, it was said that we cannot use the ketamine because it can increase the ICP, but now even the ketamine infusion is recommended for the treatment of intracranial hypertension. So we can use the ketamine for the RSI, and then we can use a neuromuscular blocking agent like rocuronium, and then proceed for the intubation.
All right. Do anyone? Yes, Nadia, you have excellently answered that. Do we have any?
I
Does
have a
anyone?
question.
Yes.
Yes.
Yes, please.
First of all, I would like to congratulate Nazia for this excellent
Yes,
presentation, followed by a nice discussion. My question is regarding maintenance fluids, especially in the first 48, 72 hours in traumatic brain injuries. Suppose, for example, we have a child of 2 years, 10 kilogram of weight, and if we calculate the amount with the full maintenance fluids, so it comes out to be 1 liter, that is 1000 ml. Okay. On the other hand, if we calculate the maintenance fluid with 70%, so that comes out to be 700 ml. So if we give fluid with 70%, it means we are giving 300 less fluid to this child. And that if definitely it's a good amount of fluid, if we give it with 70% of the maintenance, it means we are reducing her mean arterial pressure. And the mean arterial pressure falls, that means cerebral perfusion pressure falls, which will be detrimental to the brain. So what is actually recommended? One should give full maintenance or 70% of the maintenance? My question is this.
Okay, so the recommendation is that we target the euvolemia or the normal bulimia. So if you are giving a 10 kg child with a 1000 ml of the fluids and that child is completely sedated, so it's the brain and we need to maintain like delivery and the perfusion. So if the child requirement is very low, so we do not need to give the like if the child is sedated, there is no activity, and the requirement is low. So we need to maintain the normovolemia, and so we can give the 70% fluids in these children. Like we do not need to give the 100%. And in these children, so it is recommended that like in adolescents, we use the normal saline, but in these kids, we can use the full strength dextrose saline with the addition of 5% dextrose to keep the blood sugars within the normal limits. So we do not need to give the 1000 ml and it will decrease the MAP. As in these children, like in most of the situations, we are monitoring them with the arterial pressures, like we are targeting the MAP. So we can target that MAP and can adjust the fluids according to that kid. Like it is not a hard and fast rule. It can be changed from case to case, but this is the recommendation that you can you need to maintain the normovolemia and with the 70% of the maintenance fluids.
I think so. That's excellently answered, Dr. Nazia. And sorry. So in the chat box, Dr. Wasim has added to the previous question that fentanyl or etomidate can also be used. Fentanyl definitely is a drug of choice in these patients. It is 100% more potent as compared to the morphine, and etomidate and rocuronium and vacuronium can be used as in these patients. However, etomidate should not be used in hemodynamically should be used in hemodynamically stable patient, especially if anyone is suspecting adrenal suppression. It should not be used. Otherwise, it's a very good drug to be used. And if you don't have etomidate, you can use benzodiazepines or other agents and whatever you have it in your emergency or in your department. So, Sidra, do we have other questions from the participants?
Dr. Naveed, I'm sorry, I think I lost connection in between. So
Okay.
I'm not able to view the questions as such. So if you could carry
All right.
on while
So
I'll
yeah,
try to.
I will carry on. That's fine. So
Okay, thank you.
there is a question from Shahzad. What is what is the role of prophylaxis decompressive craniotomy? What's the best time to do it? And is there any role of antithrombotic medication? So there are two questions. One is the role of prophylaxis decompressive craniotomy and the best time to do it. And the other role is antithrombotic medication.
Okay, so regarding the decompressive craniectomy, there is no, we do not have any data. In the most data is extrapolated from the adult population. So it is recommended that the decompressive craniectomy should be done in the later stages, like when there is a refractory intracranial hypertension that is not responding to your medical management, or if there is an impending herniation. But in the adult population, it was seen that they have seen the patients in which the decompressive craniectomy was done early within the first 10 days. And they have shown that it have resulted in the decrease in the ICP, and it have resulted in the decrease in the need for the other medical management for the management of the intracranial hypertension. But when they follow the outcome at the 6 months and the 1 year of age, so they found that it was not associated with the good outcomes. So the exact point, like at which stage you should do the decompressive craniotomy, that we do not have any evidence for that. And regarding the whether should be bilateral or it should be unilateral, that is also we do not have any sufficient data in the pediatric population. But in the adult population, they have seen that the bilateral was associated with better outcomes as compared to the unilateral decompressive craniectomy.
I think so. Dr. Gauhar Javed can add on that as well. Dr. Gauhar, are you online?
Yes, I'm online. Role of prophylactic. The question was, what is the role of prophylactic decompressive craniectomy in kids? So there is no role for prophylactic decompressive craniectomy. The decompressive craniectomy is a procedure which has to be done as a second or third line treatment, at least third line treatment, if not second. After other measures of treatment of raised ICP have been tried and they are not successful, and the patient is deteriorating, herniating. In fact, there are some interesting points that at no point of time the ICP has been more than 40 millimeters of mercury. Sustained ICP more than 40 millimeters of mercury, because the outcome of decompressive craniectomy in such cases is not good. So this is an interesting point. And decompressive craniectomy is done only as a second or third line treatment, not prophylactically.
All right. I think so. That's totally right, in that there is no role of prophylactic decompressive craniectomy. So another question was, how do we, Nazia, there is another question asked by Shehzad that how could we confirm the DI surely in the early course of the disease?
DI can be confirmed only on the MRI imaging.
But I don't think so we can do that early in the course of the disease, as the patient are quite unstable if they are being admitted. It is usually done from the prognostic point of view later when the child is more stable enough. There was we missed the antithrombotic medications part for the TBI patients. So it was being asked by Dr. Shehzad that is there is any role of antithrombotic medication in maintaining cerebral perfusion pressure?
No.
If any other panelists or judges wanted to add on this, Dr. Humera, Dr. Tawta, Dr. Khalab.
I think even before that, we can question that is there any propensity of these patients of traumatic brain injury to pro-coagulability or not?
That's true. You have rightly mentioned in adults and they usually use it from the DVT point of view, but in children it is not being used and it's not being recommended as a part of treatment. Cedra, do we have any other questions in the chat box or?
Yeah, there is a question regarding the duration of anti-seizure medications in traumatic brain injury. So,
right.
Any comment, Nazia?
Yeah.
What I read about is that in the initial phases, it was recommended that you use the anti-seizure prophylaxis for the 2 years and then stop it. But now there is no recommendation that you stop the seizure prophylaxis for the 2 hours after the 2 years. And we need to monitor these states by intermittent continuous EEG monitoring. And if the child's compliance is good and the child is not having seizures and on the EEG there is no evidence of any epileptic form discharges, then only you can discontinue the seizure medications, anti-seizure medications.
Dr. Shahnaz wanted to add. I will just see if I can unmute her. Yes, Dr. Shahnaz, you can.
Okay. So, Nazia, did you say 2 years? It
yes,
also
no,
depends. So it also depends on the outcome. If there is neurological sequelae, if there is ischemia post cerebral edema, if there is infarcts happening, and if even for example, even in cerebral palsy, where you know that there is an ischemia in the brain, if they have not had seizures, you would not give them anti-epileptic medication. So it is very subjective to the condition of the child. Remember, children have a growing brain. So if it's an early onset injury, say example, if it is a less than 2-year-old child who's been thrown from the arms of a motorbike or whatever, has had severe axonal injury, the chances of that child recovering is way better than that of any adult who's had a head injury. So I would not have a blanket statement saying that you would give it for life or for 2 years. Each medication has their own side effects. you would, if it is recommended, to give it in the early phase because you don't want to have the seizures and causing more intracranial pressure. But that would be acceptable. But you need to follow the child and see
Yes.
what really is the need for this. So I would be
Yes,
really skeptical
Yes.
in
So
saying that.
the
I think so.
anti-seizure. Okay. So the
Yes,
anti-seizure
Nadia.
profile. So we are recommending the prophylaxis for the kids with the severe TBI, and so those children who have the longer on any neurocognitive disability, they are more prone to develop the seizures, and they have the intermittent seizures. That's why I said that we need to monitor these kids with the intermittent EEG, and if the EEG is normal, then we can stop these anti-seizure medication.
So it also, again,
So it
I
is.
sorry, beg to differ, because EEG is not something that you can start or stop medications on. You have to have clinical seizures.
Yeah.
You have to have indications of,
Yeah.
an abnormal EEG can be reported because of, sort of slow EEG. So you have to understand that you have to be clinically in that phase or suspicion of having seizures,
Yes,
and
definitely.
also if,
Definitely.
yeah, so, and if the EEG is markedly abnormal, having focal discharges, then you would consider continuing the medication. But what I'm trying to say is that I think it should be very, very individualized. And in severe TBI, if you use it for the first 7 days, it should again be, reevaluated whether you really need to
Yes.
continue or not. And if you want to monitor with an EEG continuously, if there is, no discharges, then there is no point in continuing long term.
Yes, definitely.
I totally agree with
Even if
Dr.
there
Shahnaz.
is brain injury.
It's, yeah, because usually seizure prophylaxis is being used for only shorter period, and especially in the severe TBI
Yes.
patients. Most likely they are being stopped for early 7 days, and if there is an evidence that the child does not have any clinical seizures, or if the patient is kept sedate, relaxed, and uh, there is no seizures on the EEG, then definitely it is recommended to stop it within a week, not to continue it for more period. Uh, we have raised hand, Dr. Sidra, as well as Dr. Gohar Javed wanted to add. Sidra, you can add, and then I can ask Dr. Gohar Javed to add anything.
Yes, I think I absolutely agree with Dr. Shinaz because a lot of this is more of individualized medicine. One case of TBI would differ from another. So you would probably have to end up individualizing, whatever care that you're providing. So it may, whatever treatment you're giving may not hold true for all your patients. So I think I agree there. And of course, and then there's also evidence to suggest that, using, for example, like things like a phenytoin bolus and all may actually decrease your oxygen to the brain and cerebral oxygen and all of that as well. So that again, taking that into account, we have to be very sure while you're talking about providing neuroprotection and and as to what point you need to justify using anti-epileptics. So Nazia, I had a question, I think amazing literature search you did. So did you come across any comparative studies comparing the optic nerve sheath versus imaging to suggest how you would manage your patients, because a lot of times our patients are not stable enough to be taken for the CT, let's say. So if you're talking about something like an impending herniation, so you think like in centers where we still don't have optic nerve sheath defined very well, so you think we could go ahead with that? Did you come across any studies that would suggest that there's no difference in outcomes, or if there's any difference in outcomes of using one over the other?
Sorry, I didn't get your question. The difference between the imaging and the optic nerve sheath?
No, using one over the
The
other.
role
For
of
example,
optic nerve sheath over the other.
over the other, like we even though we're using optic nerve sheath, but despite that, we're going ahead and getting a CT scan done, right?
Yes.
So yes. So is there any evidence to suggest in cases where optic nerve sheath may be used in patients where you may not be able to move them for a CT scan, and it may be as good as a CT scan to dictate your management?
Sorry, I didn't read any paper regarding this.
I think so. That's a great question. Dr. Gohar Javed wanted to add anything if we can ask him about it, considering the previous question as well, and then we can discuss about it. Yes, Dr. Gohar, do you want
Yes,
to add
thank you,
anything?
Dr. Naveed. So, the question of anti-seizure prophylaxis. The only thing that the anti-seizure prophylaxis can do is to control early post-traumatic seizures. It cannot prevent the development of post-traumatic epilepsy. So, long-term use of anti-seizure prophylaxis after TBI is not supported. One drug can be preferred over the other drug. Again, that is also not, there is no evidence that one drug is better than the other drug for preventing the early post-traumatic seizures, not epilepsy. So this is what my viewpoint is. Regarding the optic nerve sheath diameter versus imaging. So
Yep.
optic nerve sheath diameter basically helps you to decide about uh, when to do next imaging. I think there was a discussion going on that in especially in infants, one is reluctant to repeat the CT scans. So one can rely on this optic nerve sheath, whether it's necessary to repeat the CT scan in addition to the clinical data that we have, bedside data that we have. One third important point that I wanted to make is uh, coagulopathy associated with TBI. It's very common in kids. Not very common, but it's common in kids, especially after moderate to severe head injury. And there was a discussion going on of giving fluids to especially small kids. And giving too much fluids to the small kids, even that can lead to dilutional coagulopathy and can worsen the presenting lesions in the brain. So I think that uh, one has to be very careful in moderate to severe head injuries in giving fluids, especially crystalloids, because of this risk of coagulopathy.
Yeah, I think so. You have rightly mentioned about the fluids as well as for the use of ultrasonography. Uh, uh, there is no concrete evidence about use of ultrasonography versus imaging. Definitely, imaging you can sometimes it does happen that the patient is not being stable enough to be transferred to the imaging. These things can guide, and a recent review which has been published by Arun, it does show the area under curve of more than 90s, and when you add optic nerve sheath diameter as well as with the transcranial Doppler results that we're going to add on toward the more sensitivity and specificity of the results. So these are the things that can be done at the bedside. They are repeatable tests, and you can compare it from the previous one, whether what the trajectory of the patient is going. Uh, Also, we have a comment in the chat box with Kalab that people are now moving away from the prophylactic anti-epileptic drugs, and there are very specific indications for that, and they can be safely discontinued after 7 days if there is no evidence of seizures. So that's what the recent guidelines says as well. So we have, I think so we can move toward the last question and then we can wrap up. Kalab has asked about if there is any predictive severity score being used in pediatric TBI prognostication.
I think Nazia can take this question.
Yes, Nadia.
GCS score and the post-traumatic amnesia. We can actually use them for the predictive purposes, like what would be the outcome.
Any other scores you have come across which we Siddharth, you want to add on anything on that?
Yes, so we have the Rotterdam and the big trauma score as well. So even though they've been they've been validated in the pediatric population. There's like still recent evidence coming up with regards to this. So we do have quite a few scores that are available, and I think it's always a good idea to use an adjunct score while you're trying to, assess the clinical severity of a disease process like TBI. So not much in practice though, but yes, there is evidence to suggest that we have these scores.
All right. I think so. We don't have any other questions in the chat box. And I think, Nasia, that was a really great presentation, and that was a fantastic review on the TBI. You have nicely covered all the topics. And Sidra, I think, so Sidra, you can take over. And
Yes. Okay. Thank you, Dr. Naveed. Thank you, Nazia. I think, as Dr. Shehnaz very rightly mentioned, it was indeed a very elaborate journey, starting right from scratch and taking us, through the journey of TBI. And I think we had an amazing discussion. I want to thank all our panelists, our judges for their time tonight, and for the excellent discussion that we had. I'm sure it was very enlightening for all our participants. So thank you all. And we would meet end of January with our next P2P session that would be announced very soon. Thank you once again. Good evening and take care.
thank you very much, everyone, and take care and stay safe. Thank you.
Thank you, sir.